Waalaikumsalam warahmatullahi.
Can you hear me? Okay, can we begin? Are you okay?
Yes, Prof.
All right. Okay, good. So, how are you? Are you good?
Alhamdulillah.
Nampak semua you all sihat ni, makan banyak sangat lemang ni. Okay. Right. So, I think, how many of you are from batch? How many of you per batch?
141.
141. Okay, 107 is joining now, so I think the rest maybe tak join. Okay, I think let's begin with the what I try to deliver today. Okay, so this is my topic. All right, approach to patient with arthritis. So you can stop me at any time. All right, if I'm sure that this is you all know about this. Only thing that I don't know how many percent the knowledge still or orthopedic knowledge still in your mind lah. Okay, probably 50%, probably 20%, 30%. I'm not sure. All right. So what I try to cover, I'm sure that you list a few topic with other lecturers, right? Okay. So it's a bit awkward lah talking to computer cannot see you, kan? Alright, so approach to patient with arthritis. This is quite a common patient that we prepare for you during professional exam. Okay, so just an overview. I'm not sure this year whether there's any changes or not because we're going to have a meeting next Wednesday because of this PKP problem and COVID problem. But previously, the orthopedic input in pro exam is like this. So usually we don't have what we call PMP question. We just have a MCQ and OBA with a data picture, two data picture. And as usual, long case and short case. The percentage is a bit more compared to psychiatry because psychiatry don't have short case, kan? But auto we have a short case, right? So this is roughly we have the question. Okay, the orthopedic input. All right. So among the cases that usually we prepare for you in exam is like, of course, you need to know, like I mentioned before, when you first come to orthopedic, something like complication of fracture. Of course, you need to know diabetic foot, degenerative joint. If you have patient with spine infection, and then usually we call patient for spine infection. Hand case like peripheral nerve injury, or this is usually a short case. And a spot patient like ACL, PCL, and this is quite common. And if we do have patient with lump and bump, of course we can call the patient. All right. Okay. So before we go further, let's just revise a bit on the osteoarthritis. Okay. So radiological finding of osteoarthritis. A, new bone formation. Is it true or not? Is it true?
Osteophyte formation.
Osteophyte.
New bone formation. Okay, true. B, increased joint space.
False.
C, osteoporotic bone.
False.
False or not sure?
True.
True. False, true. Not sure. Oh, not sure is not an option. You have true or false on it. What about D? Subcontrol cyst?
True.
And E? Discontinuation of the bony cortex?
False.
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 Right. So at least your orthopedic knowledge still there, huh? Okay, it's not osteoporotic and it's osteopenic, right? Or it's not. It's a good bone, right? All right. What about this? Rheumatoid arthritis. Is it A true?
Prof, are you
Prof,
presenting the slide?
You cannot see the slide, is it?
No.
Yeah, we cannot see.
Oh, okay, that's why. Why? How do I share the slide? Probably. Wait. Your friend still coming ni.
Prof dah cuba untuk present now di bawah ada option.
Yeah. Okay.
And then open tab Google Chrome. That we our presentation
Okay.
here tab.
Ada nampak tak? Nampak? Okay.
Nampak.
Okay.
Nampak? Beritahu mana? I talking to computer. No? Dah nampak?
Okay, dah nampak dah.
Okay, dah nampak dah, Prof.
Okay. Dah nampak Prof kan? Dah nampak screen?
Dah nampak screen.
Okay. So balik semula. True or not? So A is the commonest, right? B, male are more common and commonly affected is false, right? C is a polyarthritis, symmetrical. So you have to look at the keyword. Sometimes asymmetrical, symmetrical. Okay. Periarticular osteopenia. This is quite a characteristic. And is rheumatoid factor anti IG into auto delivery. All right. So can I move to the next slide? All right, so when we're talking about arthritis, the group of arthritis we call arthroses, right? So of course, we have degenerative, we have inflammatory, infective, tumor or hematological problem. All right, so patient may come to you because of degenerative problem, or patient may come to you with inflammatory problem. Okay. Is it okay, or you have problem? You have a sound problem? Okay? Can you hear me?
Yes, Prof. Can you hear me?
All right. Okay. All right. So, what is the commonest complaint when patient come to you with arthritis? What is the commonest problem? What chief complaint?
Pain.
Joint pain. Joint pain. So, joint pain.
Okay.
So, what do you want to know about joint pain? Majority patient because of joint pain, right? So, what further history that you would like to ask about joint pain?
Follow the Socrates,
Okay.
ask for the side,
Mm-hmm.
and then is it the onset is stages or rapid?
Mm-hmm. Okay.
The intensity,
Okay.
is it
So of
ready?
course, you want to know when it started, all sort of features about the pain, right? Duration, nature, features, everything. Right?
Aggravated.
Aggravating factor. But what I always tell you, when you have a chief complaint, you should think of a differential diagnosis, right? Young patient come to you, the differential diagnosis can be different. An elderly patient who come to you, you should consider a few other differential diagnoses, right? Okay, what are the commonest differential diagnoses that you should entertain?
Osteoarthritis,
Osteoarthritis,
arthritis, gouty arthritis,
gouty arthritis,
rheumatoid
arthritis, right? So of course, if we group into the possible etiology, if in non-inflammatory, you can be your arthritis, right? osteoarthritis. And you must remember that it can be further into primary and secondary osteoarthritis, right? Okay, so it's not enough to say that this patient is osteoarthritis. So in the diagnosis, we know it's a primary osteoarthritis. So if a primary osteoarthritis, you must look further into the other features that support your diagnosis. What is the features or what are the other characteristics to support? This is a primary osteoarthritis or this is secondary. So same thing in your history, right? So you mentioned like inflammatory rheumatoid arthritis, gouty arthritis, okay, seborrheic, sort of thing, okay. So patient may come to you with arthritis due to infection, and the duration is very important, right? Patient come to you short duration of pain with fever, continuous symptom, more of like pyogenic. But patient have chronic problem, you need to consider atypical, right? Tuberculous arthritis, right? Okay, certain tumor also may present to you with arthritis, swelling, joint pain, okay? And not to forget certain drug that can cause hematrosis, okay? So patient may come to you with joint pain as well, all right? So pain is the commonest symptom, okay? You have to ask detail about the pain, okay? And other complaint is like swelling, right? What are the typical features or history to suggest degenerative arthritis regarding swelling?
The pain is progressive in nature.
No, I'm talking about the swelling now.
Or the swelling.
Hmm. So the swelling can be there and can be exacerbate, can be increased or can be reduced, right? Because in acute exacerbation of osteoarthritis, it can be the symptom just like a mild form of septic arthritis. Okay, so patient may complain to you. So if the swelling because of the TB, tuberculosis arthritis, and the swelling will be usually maintained, right? Or
It is
because of
intermittent,
tumor.
usually post activity, but then it plays off spontaneously.
Yeah, sorry. All right. So the other complaint is stiffness, right? So you need to differentiate and ask about the stiffness because your differential diagnosis just now is rheumatoid arthritis. Okay. So again, clarify what is the stiffness complaint by the patient. Is it a true stiffness or is it just discomfort, right? Okay. So other complaint is progressive deformity. Patient may come to you say that previously the knee or the leg, the lower limb looks normal. Over time, it become more deformed. Okay. All right. So other symptom like instability. Patient complain unable to walk in a uneven ground. Okay. And patient may have certain type of gait. Okay. Instability, usually patient come with what type of gait? What do you notice? Your patient have instability, especially over the knee.
Antalgic gait.
Antalgic gait is because of instability or because of what?
Antalgic gait.
Antalgic gait because of pain, right?
Because
It's
of
not
the
because of
pain.
instability, right? If it because of instability, what type of gait?
Usually
Lateral thrust gait.
buat bridge gait.
Lateral thrust, right? You see a lateral thrust when patient lateral thrust when you observe the patient walk and then you see that the knee give way, right? Okay. And patient also may come to you and complain progressive loss of function, right? So previously patient able to walk and now patient cannot walk anymore and patient need to use wheelchair or whatever. So this is what you need to cover in your history, okay? Because again, history is very important for you to come to a diagnosis. Okay, majority patient will come to you with severe or pain, okay, and then swelling, stiffness, progressive deformity, instability, progressive loss of function. All this you need to put in your history and try to ask whether this is present or not, okay? Okay, you know about this. Usually pain and degenerative is dull aching in nature. Okay, it quite whether it's worse after use. Okay, is it pain at rest or nocturnal pain? This is important to assess the severity, right? Severity of the pain. Okay, because at the end we need to plan for the treatment, whether this patient can be treated conservatively or this patient require surgical treatment. Okay. Localize which compartment also will help you to determine the severity and the diagnosis. Either it's unicompartment, talking about the knee, unicompartment, bicompartment, or tricompartmental osteoarthritis. All right. Okay, so severity. How you assess severity? Of course, we assess about the activity of daily living. What patient able to do now as compared to before. Okay. Not to forget about the analgesic requirement. If patient said that previously the pain usually able the pain is reduced after taking just paracetamol, but now patient may require more analgesic. Okay, not only number, also the dosage, right? Okay, and then not to forget to ask what are the side effects, because some patient we consider fail conservative treatment because the medication will not able to alleviate the pain anymore. So this patient may require surgical treatment later, right? So what are the symptoms just now?
Swelling, stiffness.
Morning stiffness, right? If more than 30 minutes, it's different. Instability, especially going downstairs, right? Locking. Why do you think that patient with degenerative having locking? Locking, usually you see patient in sport, kan? In sport injury, when you have meniscus injury. Can patient with degenerative come to you with locking or not? Is it possible patient with degenerative or osteoarthritis come to you with
Possible.
possible? What are the possible cause?
Because of fragmented osteophytes.
Yeah, okay, it's fragmented or fracture osteophyte, right? Or because of sometimes because of loose body. Okay. And then activity of daily living, you ask about what are the disability, like limited range of motion that affect the solat perform, how they perform the solat. Okay. And not to forget, now after you get the history to suggest osteoarthritis, like I said just now, you should look further whether it's primary or secondary, right? So just now you're talking about the symptom, why the patient come to you, and that require treatment. So of course we want to know whether this is primary or secondary. We look other sign or symptom, right? Other symptom or sign. Like for primary, you are looking for nodes, right? Nodes over the hand. What are the nodes, Deepo? What are the nodes that you're looking at?
Haberden notes.
Haberden's node. Right?
Bouchard.
Bouchard's node. So where do you should see the Haberden's and Bouchard's node? Proximal or distal?
Haberden with the distal.
Haberden is the
DITG.
distal. Okay. Bouchard?
Check the proximal interphalangeal joint.
Proximal interphalangeal joint. All right. All right. So this picture represent what nodes?
Herbertins.
Haberden's node, right? Haberden's node. Okay. So of course, in the history, if the patient have previous significant history of trauma, previous infection, so most likely the patient may end up to you with a secondary osteoarthritis rather than a primary osteoarthritis, right? Okay, if patient come to you relatively younger age group, okay. So most important thing, when you get all this history, you must ask yourself, why this patient require hospitalization or patient require treatment, and especially if patient require surgery. Okay, patient may tell you that patient have complaint of pain for the past 20 years, the patient taking analgesic. But for us to treat the patient, we want to know what really concern, what is really patient concern. Okay, so patient may already fail conservative treatment, and how do you assess that patient fail conservative treatment? That's why we asked just now the severity of the pain and the requirement of analgesic, if there is any complication taking secondary to analgesic. Okay, so at the end you must establish what are the main problem of the patient, because this is what you want to manage, right? If let's say the patient said, okay, he is now planned for surgical intervention, total knee. So of course, you want to ask why this patient require total knee. Is it because of severe pain, which is usually majority of the complaints because of severe pain? But some patients require surgery because of severe deformity. Okay, the leg become severely deformed or because of limited range of motion. Okay. So we need to exclude other differential diagnosis. Okay, before we establish this is a primary, you must, even though the history and the symptom and the sign really typical of osteoarthritis, but we still need to exclude differential diagnosis. Right. So that's why just now you should consider based on the possible etiology, degenerative, inflammatory, infection, tumor. Right. So you must prepare on this, because if your examiner asks you, okay, what are the other possible differential diagnosis? Okay, you should think along this. Okay, like inflammatory, it could be rheumatoid arthritis, gouty arthritis, and of course in the question or in the history just now, you should ask what are the history to exclude this. Okay, related to certain food, related to skin problem, related to multiple joint pain. All right. So all this need to be covered in your history. Okay. So your history must be broad first, can not be narrowed down to your primary osteoarthritis. Even though patient may come to you with bilateral knee and one side is already operated for osteoarthritis, on the other side you still have to exclude other differential diagnosis. And you cannot say because the other side already operated because of arthritis, this time patient come for another side of joint, for sure this is the same problem. No, we cannot accept that. So patient may have some other problem as well. Okay. Okay, so since patient usually who come to you with arthritis, I'm talking about genetic, is elderly, we want to know about whether this patient is fit for surgery or not, especially if patient is planned for surgical intervention. Right, so that's why you need to know about the past medical history, diabetic, hypertension, okay, heart disease, okay, and of course, you want to know whether patient is on anticoagulant or not, right? Why you want to know about this anticoagulant?
Bleeding tendency.
Risk of
Because
bleeding.
because you need to plan when is the surgery. This is elective surgery, right? So you should plan when to withhold the anticoagulant and when you can schedule the surgery. You're not talking about emergency, right? So if patient is on anticoagulant and you don't ask about this history, you plan patient for surgery tomorrow. When the anesthetist doing the round, they will cancel your case because certain anticoagulant require certain day to be withhold, right, to avoid bleeding during the surgery. Okay, so very important to ask about this history. Okay, of course, you want to know about the social history, like house condition, wife condition, right? Okay. But I'm sure that you all know this, just whether you can remember or not. Okay, again, your limitation now, you cannot come to the ward yet. I'm not sure whether you are allowed or not. Have the pharmacy tell you whether you can come to the ward now or not? When you're supposed to come back to the campus?
He will come back to UIA in 29 June.
29th of June. So to UIA, but to the hospital, you're not sure yet, right?
Maybe 13 July.
13 July, probably you will be able to enter the hospital. But of course, hospital now
yes.
is different from what you have now before now. So when you come here, you need to probably you need to wear PPE level 1. You need to retrain about the SOP, and then the teaching also will be different lah. It's not like before, whether when you are with us last time kan. Probably you are not allowed to go to HTA because HTA is gazetted as a COVID hospital. So there's some limitation, alright. And then the revision also is a bit difficult. I'm talking about face to face, whether you can examine the patient like before or not. So I think from Maski also is planning what is the best for you lah, because it's depend on Kementerian and MOH whether they allow you or not lah. Okay, the exam also, I think not sure yet whether they will conduct like before, 1 long case with 3 short cases. Yeah? I'm not sure yet. Okay, so as a lecturer also we need to modify. Probably if you are able to come to hospital later, maybe only not more than 5 students are allowed to be with patient at one time, not like before, maybe 10, maybe 7, maybe 20 ke 15 ke. So I'm not sure yet. Okay, so we just pray for the best lah. Okay, this is unprecedented event, so you have to accept lah. So again, you need to recall lah. Okay, so physical examination like before, your look, feel, and move. In orthopedic, look, feel, move. So you already cover the history. Patient come to you with joint pain. You ask about the severity of the pain, how it started, how bad is the pain, how affect the activity of daily living by the patient. Okay, you look for other symptoms, instability, deformity, reduced range of motion, reduced function. Okay, and you exclude other possible diagnoses like inflammatory, infection. Okay, and now you are looking for physical examination to support your diagnosis. Okay, so be systematic. Look, feel, move. Of course, in orthopedic, if patient able to stand, you would like to examine patient during stand or standing, because majority of the finding are better seen or detected when patient is standing, right? But be careful when patient come to you with knee pain, talking about osteoarthritis of the knee. So even though you should look or examine during patient standing, but you have to see patient individually. Some patient cannot stand quite some time, right? So you have to quickly look what you want to see. And you can, okay, makcik, diri, nak tengok semua. Cannot lah, okay, you have to see quickly. So look from in front, look from the side, and look from the back, right? So you have to plan what you want to look from in front. Okay, usually from in front, what can you see when patient standing in front of you? You want to see what? Obviously, is
Varus and varus.
deformity, right? You want to see
Deformity.
whether varus or valgus. Majority patient will come to you with genu varus. So if you see patient have genu valgus, and then you should think this is not a typical osteoarthritis. You should think of some other underlying problem. Okay, right. What else that you would like to see when patient is standing? Yeah, obviously can be seen. Front in front. You can see a scar. You can see a swelling of the knee. You see the swelling, but you don't examine swelling while patient standing. But you can see the different, whether the knee is swollen or not. Okay, what else? Muscle wasting, right? So muscle wasting. Muscle wasting is better you see from when patient is standing from in front. So when patient lying on the couch, maybe you not be able to see unless it's quite significant. Okay, this is from in front. What about from the side? What should you see from the side? What do you want to see when patient standing and you want to see from the side?
Also the deformity such as genu recurvatum and genu apa ni?
Procurvatum. Okay, the term is
Yes.
procurvatum, not genu. Genu is from in front. So when the procurvatum or hyperrecurvatum, alright. So you want to see whether patient have flexion deformity or not. Usually patient have flexion deformity, right, rather than hyperrecurvatum. Hyperrecurvatum, you expect to see in patient with hyperlaxity or patient with the ligamentous problem. So usually patient with arthritis, whether you want to see patient able to stand straight or patient has some flexion. So if patient is standing on flexion, so you should assess later whether this is a fit flexion deformity or this is just because of other reason. Right? And then you should examine patient from the back. Okay. So what do you want to see from the back? Posteriorly.
Any bakeries?
Any Baker's cyst. Okay. What else?
Varicose vein.
Varicose vein. Right. So varicose vein, because you want to plan for the surgery later. So you should look for that. Okay. So look for the finding which is obvious when patient is standing. So remember, when patient is lying on the couch on supine, you may not be able to see swelling properly at the back, right? Okay. After that, load, feel, and move, and do a special test when it's relevant. Okay. So of course, you want to see whether patient is obese, morbid obesity, or overweight. Okay, mentioned just now how the patient stand, the deformity, right? So like in this case, what is obvious here? Which side you think that is more problem? Right or left?
Right.
Right.
So looks like right hand. Right is more genovarus, right? Okay. What else that you can see from this picture? What else that you can see from this picture?
muscle wasting of the quadriceps.
Muscle wasting, right? Especially at the VMO, you can see that it's muscle wasting at VMO. All right. Okay. So what else?
Baker's cyst.
Baker's cyst. Do you think the patient have Baker's cyst? So do you think patient have Baker's cyst? It look like symmetrical, right? Because it is usually extra or additional or pouch, kan? Okay. So like this. Okay. So you can see the difference just now, right? This is more uniform, but this one you can see. All right. But of course, you can see patient when patient lie on prone position, right? Okay, talking about gait just now. Okay, so after patient stand, you ask patient to walk, and now you want to see whether patient have antalgic gait, instability with lateral thrust, especially when patient have a genovarus. Okay, but be careful if patient not able to walk, so you're not supposed to ask patient to walk. If patient need to walk using a walking frame or using the cane, so you observe how the patient walk. Okay, right. Okay, and then you put patient on supine. Okay. What you want to see now? Now you can examine the swelling properly. Just now you just observe in general. Okay, this swelling of the knee. Now when you put patient on supine, okay, you are looking at the gutter, right? Your medial and lateral parapatellar gutter, right? So whether it's fullness or emptiness, right? So if there is a swelling like this, and then you need to determine what are the swelling, what are the nature of the swelling. Is it fluid or is it mass or is it because of a soft tissue? Right. Okay. So wasting just now you can see and you can measure. In fact, if this is not very obvious, so you should measure if there's not obvious. If it's obvious, you don't have to measure. All right. So where should you measure? It's around 12 to 15 centimeter from the superior pole of the patella. Or okay, so must be consistent. Okay, not so important if there is a very obvious. All right. So just now, if you see the patient's not standing straight, you need to determine whether this is because of feet flexion deformity or because of ligament problem. So this is how you assess feet flexion deformity. Very simple. It's not like feet flexion deformity of the hip. Feet flexion deformity of the knee is very simple to assess, right? I hope you still remember. You just hold at the edge of the bed, you hold the heel and you just elevate. So if patient have no problem with the joint, so they will get the full extension. So in this case, after you elevate, you see that the joint is not straight. Okay, so it fits in this position. So only that you can justify this patient have feet flexion deformity. And how you measure the degree is basically from the femur and the shaft of the tibia. So how many degree? 30 degree, 40 degree, right? So it's very simple, not like hip feet flexion deformity of the hip. What test should you do if you assess feet flexion deformity of the hip? What test do we use?
Thomas test.
Thomas test. So Thomas test involve a lot of things, right? You need to you need to fix the pelvis. You need to make similarly flex the normal side and see whether the other side is in flexion or not. Okay. So the feet flexion of the knee is very simple. You just elevate at the edge of the bed, elevate the heel, and see whether the knee is fully extended or remain in flexion. All right. Okay. Now this is the test. If you refer to your appli, how to assess the fluid based on the amount of the fluid, right? So you have many ways. I'm sure that your lecturer also, different lecturer teach you different way. Okay, but if you refer to appli, this is what appli suggests to assess the fluid. So you have a cross fluctuation for a gross fluid. For patella tap is for a moderate, right? So a bulge test is for minimal.
Small.
Or very minimal. Okay, Juxta Patella Hollow test is just when you observe a patient flex the knee. Okay, so how do you do cross fluctuation test? How do you do a cross fluctuation in patient and gross fluid? How do you do? It's very simple, right? So you just compress the hand, your hand on the one side to empty the space. Okay, and then you straddle in front of the patella. So if you squeeze alternately, you can feel that the fluid is moved to the other compartment. Okay, so if the amount of fluid is minimal, you cannot do this. Okay, or if the fluid is moderate, this is only for a gross amount of fluid. Okay, so for moderate, of course we do a patella tap, and patella tap. Okay, and then for little or minimal fluid, we do a bulge test. So how do you do a bulge test? So we need to empty one side. Of course, we need to squeeze from the suprapatella to make sure that all the fluid accumulate in the joint, and then empty one side, so you can see that the fluid move to the other side. So and then we squeeze or we push on the other side, and the fluid will go back to the other side. So in this picture, you show that okay, you empty the fluid on one side first, from right or from the medial to lateral, and then you push again from medial to lateral. You can see that the fluid move. Okay, so this is for a minimal amount of fluid. So the other test is what we call a Juxta Patella Hollow test. Okay, in which the hollow disappear when you flex or patient flex the knee. So this is just for observation, right? Or for what we call inspection. We want to see whether this is a joint, this joint have a fluid or not. Okay. So if this is because of the mass, so the hollow will remain. Okay. I mean the fullness will remain. Okay. So sometimes in the exam you always confused what to do and with the amount of weight. Everybody just do patella tap, whether this is moderate or this is uh, gross. Everybody just follow, just ingat buat patella tap. So you have to know patella tap is for moderate, okay, gross fluctuation for the large amount, and bulge tap for a minimal. All right. Any question? All right. Next is you must locate the tenderness. Right. You must know what are you palpating, where, and for what you're assessing what structure. Okay. Sometimes what we see, what we observe during the exam, because we cannot blame you because your orthopedic input was about maybe 1 year, 18 months, 15 months ago, right? So the moment you hold the knee, we know already. Oh, last time you hold very good, but now when you hold, we don't know whether you touch exactly to assess the knee properly or not. But luckily, when during the professional exam, only one orthopedic surgeon. The rest is maybe medical, psychiatry. So they also forget how to examine knee properly. So this depends on the examiner. Okay, but if you do the examination like this during and posting exam, so probably you fail. Okay, so most importantly, you need to practice again. After 18 months, 15 months, 12 months, and then I'm sure that you forgot it. Right. Boleh ingat lagi ke you how to examine the knee? Kalau tak ingat you buat lah, balik buat sendiri. Okay, so this is what you have to do. You want to assess tenderness. Okay, so you have to be systematic, right? Start with your landmark. So usually we start at your tibia tuberosity. You go medially along the medial joint line because we are assessing in elderly we assess the compartment, right? Medial compartment. Okay, and then you go laterally to assess the lateral compartment. Okay, so tenderness, the medial joint line indicate medial compartment arthritis. Lateral joint line, lateral compartment, compartment. So the other compartment of the knee is, what's the other compartment of the knee?
Interior
Patellofemoral. Okay, patellofemoral. So medial, lateral, patellofemoral. How do you assess patellofemoral arthritis?
We do a grinding test.
Okay, a grinding test. So you do a grinding test in extension or in flexion?
Extension.
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 Why not in flexion?
You cannot even move the patella in flexion.
Oh, you cannot even move the patella in flexion. Some other reason? One other reason why you must do in extension?
Patella will glide away at the femoral condyle during flexion.
Glide away.
Glide at the femoral.
Because when you extension, the patella is in contact with your femoral condyle, right? So that's the most contact of patella and femoral condyle. So when you grind the patella during extension, and then you really assess the patellofemoral joint. Okay, but usually this one is very painful. So usually we reserve at the end of examination, so that patient can still cooperate with you for you to continue with other examination. But if you reserve this patella grinding at the end of examination, you must remember. Sometimes you forget after you do everything and you forget to do this. So be careful. Okay, when you assess for tenderness, your eyes is always at the patient face, not at the knee or at the joint. Okay, you may not able to detect if patient in pain or not, right? Okay, so remember, if patient cry, you also cry. Patient not supposed to be in pain. You must respect the patient as a patient, a subject. Okay. All right, and then you want to assess the patella facet. Okay, and you squeeze one side and you feel. Okay, and the other test is you assess for a synovial swelling or Solomon test. What we try to do is you try to lift the patella, and if the synovium is thickened, your finger will slip off from the edges. So this is in certain case like TB apa ni? Tuberculosis arthritis, right? Okay. So next, load, feel, and move. Remember that move is active first, and then only followed by passive. Okay. In the exam, sometime in you punya exam, you rushing and you're anxious, you do straight the passive. No, right? So you should supposed to ask the patient to do the active range of motion first. If patient already have full range of motion, and then that's it. But if patient have limited active range of motion, you want to know why. Is it because of stiffness, or because of contracture, or because of pain? Okay, it's contracture meaning that you cannot move anymore, right? It's stiffness, maybe certain movement will be able to do with passive. Okay, but if patient because of pain, you stop. Okay, you will report. Okay, patient have further movement improve with a passive. However, I cannot proceed further because patient is in pain. And then you report range of motion. Range means from one point to one point. Okay, if patient have hip flexion deformity, so your range of motion may start from 30 degree to, let's say, 100 degree. Okay, if patient have full range of motion, maybe start from 0. Alright, so you must understand the concept of hip flexion deformity just now. Okay, sometimes you are interested to see, oh, now I can feel the crepitus. Okay, when you move, it's crepitus. Okay. What about other tests? Do you need to do the whole the complete test of the knee? Drawer test, McMurray test, valgus varus stress test. If you have time, you should do this. Okay. If you don't have time, the most important thing you must do varus and valgus test, because you know that patient come to you with deformity, and the deformity is either varus or valgus. So this is important for you to assess the integrity of what ligament? Collateral ligament, right? So drawer test, why is it important for you or to assess? You want to see whether the patient have intact, especially PCL, posterior cruciate ligament. Why? Because certain implant have what we call a PCL sacrifice, meaning that you can remove all the PCL or the cruciate. Okay, and some what we call implant require integrity of the posterior cruciate ligament. We call posterior PCL preserve or PCL retain. Okay, that's why you need to do drawer test also. Okay, what about McMurray? Should you do McMurray? Not necessary, right? Because anyway, you need to cut the articular surface in order to put the new joint, right? So meniscus is not very important, whereas valgus is very important for you to demonstrate whether the patient have ligament laxity or not. Okay, drawer test also want to assess, especially PCL. Okay, so later you should be able to come up with a diagnosis. Okay, diagnosis. If you say it's osteoarthritis, which compartment? And primary or secondary. So you should be able to say, okay, my diagnosis is tricompartmental primary osteoarthritis of the right knee. This is a full diagnosis. You just cannot say my diagnosis is a osteoarthritis, osteoarthritis of the knee. It's not adequate. So which compartment is involved or are involved? Is it primary or secondary? Okay, and of course you need to support with your history and physical finding just now. Okay, so any questions so far?
Prof,
Yes.
my name is Faris. I would like to ask, in the case of fixed flexion deformity of knee, how do we differentiate whether it is a true fixed flexion deformity or is that is it an extension leg?
Extension leg is different, man. Extension leg means that what are the possible cause of extension leg?
Muscle weakness.
So your quadricep mechanism is problem. Patient cannot complete the extension because of extension mechanism. probably because quadricep atau ligamentum patella. So in extension leg, passively you should be able to get the full extension. Patient may not able to complete the extension actively, but passively you should be able to do to help them. But in case of feet flexion deformity, so even you try to move further from the point of feet flexion deformity, you cannot get. All right.
Okay.
So that's why you need to differentiate. If extension leg, when you elevate the knee, so you will get the range of motion will be normal or 0.
Okay,
Is
Prof.
it clear?
Yes, yes.
Okay, any other question?
Assalamualaikum, Prof.
Yeah.
I have one question about the knee examination. Do we need to do neurovascular examination or any
Okay, of
other?
course. All right, now I'm completed just now at the knee examination. Of course, look, feel, most a special test, right? Special test means that you need to assess the neurovascular. Okay, you need to palpate for the pulse, look for the circulation, because important as a surgeon, you want to know whether this patient have a good vascularity or not. If patient have problem with vascular, let's say pulse is not good, okay, and the circulation is not good, probably they will decide intraoperatively this patient, when we do surgery, we cannot use tourniquet. All right. And of course, the nerve just now, what nerve are at risk if you do the surgery later? What nerve? If you do, let's say you are talking about total knee replacement, what nerve are at risk?
Common peroneal.
Common peroneal, right? Because when you release all the soft tissue, you put your retractor. Sometimes it can cause injury. So you must assess before surgery whether the neurovascular is good or not, intact or not. And then post-operatively, you need to assess, okay, whether this is intact or this is compromised. Okay? All right. So look, feel, move, a special test just now, varus valgus, drawer, and complete with your neurovascular examination. Okay? All right. Any other question?
In the case of osteoarthritis, did we expect patient to have a fixed flexion deformity, Prof?
Depend on the severity, right? Some early stage, maybe patient have full range of motion. That's why just now in your history, what are the problem with the patient? Majority patient come to you with pain, but of course some patient come to you with limited range of motion. So in this case, you really need to assess motion whether patient have flexion deformity or not. So how do you know that? From the history, from the physical examination, why patient standing just now, and you do fit flexion deformity, and only later, okay, you commit this is fit flexion deformity, and further support by your X-ray later on, especially when patient have already tri-compartmental osteoarthritis. Of course, if a primary, early unicompartmental, you don't expect patient fit flexion deformity, right? Okay, so not all patients will come to you with flexion deformity. Depend on the severity and stage of the disease. Okay. Any other question?
Prof?
Yes.
My name is Elia. I have a question. If patient presented with lateral arthroses, should we do the dive test to see the involvement of the
Dial test, basically you want to see like posterior corner instability. It's more of the spot related problem lah. Okay, so I'm not really expected to be done for patient with degenerative arthritis. More importantly, you need to do your varus and valgus test. Okay, so this one also you need to practice again. Sometimes when we examine you, your professional exam, you don't know where to put your hand, especially if patient is bigger than you. Okay, so how do you open up valgus and varus close up? So that's why you need to do it properly, right? And whether you need to do it in 30 degree or 0 degree flexion. Okay, so For degenerative, I suppose you don't have to do a dial test, right? Okay.
Okay, thank you, Prof.
Okay, any other question?
Prof, just now we
Mhm.
we learn about whether we have to determine whether it is gross, moderate, or minimal, or little fluid. So my concern is that if we in the exam, in short case, if we go blind whether we don't know it is gross or moderate fluid, how to decide whether we want to do cross rotation or patella tap or Bulge cut?
All right. So if you remember just now, we start with inspection. Okay, when patient is standing, you want to see whether the knee is swollen or not. Okay, and then you put patient on the supine, on couch and supine. So what do you do just now? You inspect whether there's a loss of medial and lateral parapatellar gutter or not, right? So if obviously you cannot see the gutter, so you cannot say this is mild or moderate, right? It must be gross. But if the gutter is still present, but not normal compared to the other side, so it either moderate or minimal, right? So based on that, it will give you an idea. Okay, so if already you see that okay, there's loss of gutter, the swelling is very massive. Takkan you nak buat Bulge test or you nak buat patella tap, it's already wrong, right? But if you see patella patella gutter is still present but obliterated, become moderate. Okay, if you see not much different compared to the normal side, patella the gutter is there but just little bit obliterated, so it could be a minimal fluid. Okay, so you do it based on the other finding as well. Okay, I'm answer your
Okay,
question.
Prof. Thank you. Yes, thank you, Prof.
All right. So any other question? All right. If not, of course, you make a diagnosis and then we ask you what are the relevant investigation. Okay, so you know that if the exam, we should discuss anti-management, right? So when you plan your presentation in 30 minutes, you plan the history and physical finding, and you should try to bring us to management so that you are quite comfortable with the mark later on. So of course, investigation is either supportive or confirmatory. So listen to, sometime in the exam, we just want you to give, okay, how do you confirm your diagnosis? So you must listen to the question. Okay, if you have more time, okay, and then we ask you, okay, we let you, okay, what investigation you would like to do, blah, 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 right? Okay, so like in this case, confirmatory biasanya is radiology, right? Radiology. Okay, so we give you a radiology picture or a radiograph and we ask you to interpret. Okay, you are expected to interpret this radiograph in detail lah kan. What are the cardinal sign kan? Remember the cardinal sign of osteoarthritis? What are the cardinal sign?
Narrowed joint space.
Narrowed joint space because of what?
Because
What are the mechanism that cause narrowed joint space in the
Cartilage
radiograph?
destruction.
Of the disc degeneration.
Again?
The disc degeneration.
Cartilage destruction.
Thinning of the
failure of having
cartilage.
cartilage.
Thinning of the cartilage because cartilage is supposed to be radiolucent, right? So when the cartilage become thinning, so that's why you see that reduced joint space. Okay, number one. Number two, what are the features?
Marginal osteophytes.
Marginal osteophyte. What is marginal osteophyte? How the marginal osteophytes develop?
Because there's a new bone formations.
It's because of new bone formation. All right. All right. What are the other signs?
Subchondral sclerosis.
Subchondral sclerosis. Why subchondral sclerosis?
Because the load of the patient have been subjected to the bone, the subchondral bone.
The load.
Because of the failure of the cartilage, so the stress goes to the subchondral bone.
What are the explanation? Unequal distribution. That one may cause either union compartment or because varus or valgus. Okay, what are the other signs?
Subchondrosis.
Why subchondrosis develop in osteoarthritis?
because of the penetration of the synovial fluid into the subchondral bone.
Into the coalescence of the microfracture, and then with a intrusion of the synovial fluid, it will cause subchondral cyst. Subchondral sclerosis, basically, you remember that osteoarthritis is a process of healing and repair. Damage and repair. So subchondral sclerosis because of the repair process of the cancellous bone. Okay, so you have reduced joint space, marginal osteophyte, subchondral cyst, subchondral sclerosis. Okay, and of course other features like genu varus or genu valgus. Okay, sometimes you can see the loose body if you are if patient have loose body. Okay, so remember that marginal cardinal sign, and if you know the reason underlying that is better. All right, so in this case, what else that the finding? You can see that which part is more affected?
The medial side.
Medial side, right? And then if the medial side is really affected, of course, you expect the patient have genu varus, kan? And then you see that marginal osteophyte here. Okay, subchondral cyst maybe not very clear on the X-ray, especially dalam ni. Kalau we give you a true X-ray, probably you may be able to identify that. Okay. All right, this is your cardinal sign. Okay, cartilage erosion, revascularization remaining cartilage and capsular traction, subchondral cyst, synovial fluid intrusion into bone, subsclerosis repair or healing of microfracture, and loose body because of fragmentation of osteochondral surface. Okay, it's good if you know this, okay, cardinal sign and why they develop this. Okay, so how do you diagnose osteoarthritis? What are the criteria that you use? Usually we don't ask really what this criteria lah, but good if you know. Do you know the criteria to diagnose osteoarthritis?
Category Lawrence.
That one is because the one depend on the severity, kan?
Do you use the ACR?
ACR, okay. What is that?
So based on ACR, there is a clinical and also laboratory everything, or clinical plus radio,
Very
or
good. Okay,
the third one is only clinical.
very good. Okay, it's very good. American College of Rheumatology classification, right? Okay, you have this clinical and laboratory. Okay. So for idiopathic like knee pain, the duration, the age, the stiffness, crepitus is clinical and laboratory and radiograph finding. Okay. But usually we don't really ask you about this, okay? Because usually it's by clinical radiograph is adequate. So management, of course, we start with non-surgical management. I have to optimize. Remember that surgery is usually the last option. Surgery is not for everybody because we must really select the patient appropriately. Okay, so the patient must understand, okay, what do and don't, what the expectation also. So non-pharmacological treatment, pharmacological treatment, conservative treatment, physiotherapy, strengthen the muscle, improve range of motion, okay, improve the gait. This is important. Non-surgical measures that we need to start. Okay, once we exhausted with this non-surgical treatment, only we ask about or we plan for surgical treatment. That's why just now when patient come to you with a chief complaint of right knee pain for 15 years, so if you give this chief complaint, and why patient admitted after 15 years? So you need to really go into deep. Why this patient require admission now or require surgery? So it probably because of failed, not or conservative treatment, or patient really have a progressive deformity, for example. So this is the important point that you must ask the patient. Okay, so non-pharmacological like education, exercise, weight loss, okay, ambulatory assist device. Okay, so you need to know. Okay, maybe start with cane, one, or walking frame, wheelchair. Okay. Okay, this is how you exercise now. Okay. Analgesic. You have step ladder analgesic. Okay. NSAID. Do you give intra-articular corticosteroid injection or not? Do you give to the patient? Is it contraindicated or not? Corticosteroid injection.
No.
It's not absolute contraindication, but you cannot give routinely, right? Okay, it's not absolute contraindication. Intra-articular injection is in terms of usually you give a supplement, right? So you have your viscoelastic injection. So you have a lot in market like Vitrol, Atril, whatsoever. Okay. So remember that intra-articular injection is only for early stage of arthritis. So if patient already come to you with tri-compartmental and you suggest, okay, we ask you what else that you want to suggest to patient? You say that intra-articular viscoelastic supplement. So it's wrong. So if a patient come to you with early stage uni compartment, and you may consider that. Okay. So when you consider surgical management, of course, when persistent pain, which is unresponsive to conservative treatment, or I mentioned just now with progressive deformity, or patient have really problem with ambulation, instability. Okay, but majority because of pain. All right. So when we counsel the patient, we say that okay, majority of the pain can be reduced after the surgery, but the range of motion probably patient not able to get full. Okay, so expectation of the patient must be explained before you do the surgery lah. Okay. Okay. Beside that, some of the surgeon may before do a replacement they do the arthroscopy. Okay, arthroscopy to what we call arthroscopy debridement of the osteophyte. Osteotomy is an option for a secondary osteoarthritis ataupun primary osteoarthritis in relatively young patient in minimal involvement, like just a one compartment, usually unicompartmental arthritis. So we already patient have already tri-compartmental, and then osteotomy is not the option. Why we do osteotomy? Because we want to redistribute the weight. Okay. So remember, this is osteotomy. We call a high tibial osteotomy, indicated in young patient. Okay, and only usually unicompartment involvement. Okay, we're talking about replacement, of course, in older patient and more severe involvement. Okay. What about arthrodesis? Usually arthrodesis we reserve to a pathology, right, or secondary arthritis. Let's say patient have septic arthritis of the knee, and then patient come to you with osteoarthritis changes with severe pain. Okay, so in patient with underlying infection, replacement is relative contraindication. Okay, so we don't want to do the replacement in patient with underlying infection. So you can buy time, do arthrodesis. But if patient is primary osteoarthritis in the elderly, arthrodesis is contraindicated. Okay. And arthrodesis also we use to salvage failed arthroplasty, meaning that some arthroplasty end up with complication, let's say infection, for example. So you remove and you need to arthrodize. So it's not a primary surgery, but it can be a salvage surgery, arthrodesis. All right. So if you see the step ladder just now, start with simple. Sometimes just arthroscopy is not the standard that every surgeon do this. Okay. In younger patient, less involvement, you may consider osteotomy. Okay. When involved only one compartment. And then if patient already in advanced stage, of course we consider arthroplasty or replacement surgery. Arthrodesis, usually for secondary osteoarthritis due to infection or a salvage arthroplasty. Okay, I think that's about all as a revision, because this is quite common, and I'm sure that there are many patients, Prof and many patients I think he will bring during the exam lah. If patient willing to come lah. But usually every year memang ada lah patient yang arthritis. Okay. Any question?
Prof, I have a question.
Okay.
For those that has undergone surgery, do we need to continue all the pharmacological and the pharmacological, I mean like the NSAID and the pain relief analgesic for patient post-op?
Okay, of course, I said just now, usually the pain is because of the damaged joint. Okay, once you remove the damaged joint, so the pain usually will reduce tremendously. So the amount of the pain may be not there anymore. So analgesic is basically just PRN lah. Okay, probably that's why most important thing is not only surgery but preparation before the surgery. You need to what we call prepare the patient physiotherapy, gait, gait. You just imagine a patient not walking quite some time because of knee pain, and you do a surgery today. Okay, you correct the alignment, everything, and tomorrow morning when you do round, okay, mencik jalan. So what do you think? Patient not working for quite some time, so that's why you need to prepare. Okay, strengthen the muscle, improve the stability. Okay, and then start physiotherapy. So probably because of that, you may need continue analgesic for rehabilitation. Okay, right. Any other question?
Prof, if patient is young patient, for example, athletic patient coming with a secondary osteoarthritis and the pain is unbearable, so we opt for surgical management. What are the best choice of option for this kind of patient?
So if you remember just like I said, if young patient, young relatively less than 50 years old, uni compartment, okay. You remember that arthroplasty total knee is the point of no returns. Okay, we try to preserve arthroplasty for elderly patient because the revision surgery is more difficult and is related to wear and tear. So if you replace in young patient because of their requirement, because of their activity, they tend to fail. So we try to reserve arthroplasty for elderly patient. So we hope that one surgery is for all. I mean that we do have to do revision, and the longevity of the implant is not more than now is I think 15 years or 20 years. So let's say patient come to you at age of 49, 50, is relatively young. Okay, and then if you assess only one compartment is involved, okay, and the X-ray also show is one compartment only involved. So there's two options. One I said just now is we do the osteotomy. Osteotomy that we realign so that from the varus they become straight. So we call high tibia osteotomy. So the other option is we do a limited arthroplasty. So we just remove the compartment yang involved. So we call uni compartment instead of total knee replacement. Okay, faham? Alright, so we try to preserve not to do a total knee in a young patient. Okay, but if young patient because of infection, let's say previous history of septic arthritis, there's an option for you to do arthrodesis. Okay, but let's say the patient developed osteoarthritis secondary to SLE. SLE, so you know SLE is ongoing disease. So what option that will you suggest to patient? Or sometimes severe rheumatoid arthritis. So what option? Do you arthrodize? Do you do total knee? Do you do a replacement? Or what? Some patient on as an ongoing disease, SLE, rheumatoid. So you know what? What option?
Arthrodesis because there is a secondary pathology.
Arthrodesis. You agree? Do you agree?
The medical.
No, Faris. That one we don't do arthrodesis. We still do a revision. We do a total knee or total. I mean that we do a arthroplasty. Okay, because it's ongoing disease. But of course, we need to maximize, or we need to optimize the medical treatment, and then we need to inform the patient that patient may require revision later. All right. So that one is different. It's not like because of infection. This is ongoing disease. Patients on steroids sometime. Okay. All right. Okay. Any other question?
Prof, there are questions that they sent in the chat.
Okay.
Should I read it?
Do we need to know the complication of replacement? Okay, of course, to differentiate that average student and a good student, kan? So, of course, you should know, kan? What are the complications of replacement, total replacement? So, you can discuss regarding the intra-operative and post-operative, right? So, intra-operative like bleeding, okay? Okay, post-operative like infection. Lagi? Apa lagi?
DVT.
DVT, the one that is extra, what we call risk of DVT, beside your virtual triad is surgical or surgery to the joint, especially knee and hip, besides spine lah. Okay. Okay, Prof, why we need to know the integrity of collateral osteoarthritis? So what do you think? Because as a surgeon, later on, if the joint is very unstable, so they need to plan the surgery. Whether this is involved the use of the implant, also the surgical technique. Okay, so if the surgery is very when the collateral is very lax, so they need maybe to do the release or the cut. So this is mainly to make sure that at the end, after the surgery, patient have a stable knee. Okay, no point that you do everything looks good in the X-ray, but patient cannot use. Okay, okay, all right. So I said just now also for the PCL. Okay, if the PCL is intact, so you have an option. Let's say we use a PCL preservation type of implant. If the PCL also gone, now you know that you need to remove everything. You need to remove the meniscus. You need to remove the ACL, PCL. So this is regarding the implant selection later lah. Okay, but for you, okay, you want to know what are the findings now. Now the finding, which compartments are involved, medial, lateral compartment, posterofemoral. What about the ligament? Is it ligament lax or not? Okay, that one is important because it'll give you an idea what you need to do. Okay, or you prepare. Okay, the question, in what case we do excision arthroplasty? You know excision arthroplasty? This one usually for hip. Okay, for the hip. Okay, excision arthroplasty means that patient come to you with the hip problem. Okay, and then you cannot preserve the hip, so we cut the femoral head. Okay, and then we don't replace, we don't do total hip. Okay, so it's just the joint and a loose joint. Okay, this is another salvage procedure, especially macam patient with severe infection seperti arthritis ke, yang not suitable for replacement. Atau in my practice in pediatric patient, let's say in case of CP, patient yang severe cerebral palsy, okay, and then the hip is dislocated and cause painful hip. So that one we call we do a excision arthroplasty. All right. Okay, any other question? Okay, if not, I think that's about all from me. So I wish all the best for you. I'm not sure whether we can have a physical class for revision or not. Pray for the best. I think you still need to see patient lah. Okay. I don't feel online ni dia tak sampai tau. You duduk kat rumah tengok atap ke, tengok ceiling semua ke. So dia tak sama. Right, if you see patient. But this is what we call a new norm kan. So you have to adapt on that lah. So all the best. good for you. Hopefully all of you will pass the exam later lah. Okay. Okay, thank you. Assalamualaikum.
InsyaAllah.
Thank you, Prof.
Thank you, Prof.
Okay, bye-bye.
Thank you, Prof.
Thank you, Prof. Thank you, Prof.
Thank you, Prof.